This conference will now be recorded.
We'll start with you, Jake.
I don't have anything, Len, tonight. I did have a blood test on Friday, but I didn't get the results back yet. So probably next Tuesday I can say whatever it is.
Right. Okay. And next up, Dennis Correa.
I don't have anything tonight, Len. Thank you.
Okay. Jay Curran.
Yeah, I would. I may be. My doctor may be wanting to put me on Xtandi or Apomethadine, and I'm wondering. I think I heard something about if you failed Zytiga is about a 15% chance that
Okay, we'll talk about that.
that might work. Go ahead. Yeah.
Thank you. We'll get back to you. And Jay number 2, Jay Kruckman.
Nothing for me tonight, Len. Thank you.
Okay. And long time no hear from Jeff Markey.
Yeah, hi. Sorry.
Hi.
I've got a couple of pretty interesting things having to do with the major hot flash problem I'd been having for a long time, as well as a major muscle weakness problem. And I've got some interesting information on both.
Great. We'll look forward to you sharing that with us. And John Appler.
No, Len, I'm okay. Thanks for asking.
Okay. And I don't have anything new to talk about today, so we'll move on to Les Shelderup.
Nothing tonight, Len. Thanks.
Okie doke. Paul Frieda.
Yeah, I've got an update tonight.
Okay. Thank you, sir. And no one else new joined, Jake?
Not yet.
You want to wait a little bit more? Let's see. Do you know what time it is?
It's 8:07 my time, Eastern time.
So how long does Rick usually wait before he gets going?
Another couple of minutes. This is a pretty, it's a pretty good group already. So we'll probably have a few stragglers. Sylvester usually manages to log on a little bit later, but everybody else is usually here by this time. So I guess you can start. Unless everybody wants to wait for Rick, and I don't have any idea when he's coming back.
Yeah, not sure we should do that. I think, didn't he even tell you he may not come back?
No, he said he would make it, but he needed to go out and exercise, and he was frazzled. He had a million things going on, and nothing was going right, and he just needed to clear his mind, he said. So I assume he's coming sooner or later. But yeah, I don't think we want to wait for him.
No.
He can listen to the recording.
And I've been there.
No, me too.
So, we can start then with you, Jay Curran. You're in San Francisco, you said?
Yes.
Uh-huh.
Oh, wait a minute, Len. Let me. One other caller just joined.
Okay.
Person on the telephone, would you like to tell us?
This is Sylvester. Sorry, I'm late.
You heard us talking about you, didn't we? Didn't you?
Yes, I did, and I'm trying to get you on this machine, but I'm getting some unusual messages.
Okay, you're probably the waiting for name that we see. That's probably you also. That's okay. We can, you can listen to us while we're going on. Welcome to the call.
Thank you.
Go ahead, Len. I'm sorry.
Are you just going to be listening tonight, or do you want time to talk?
No, I don't have anything to say, but thank you anyway.
Okay. I'm sorry, Jay Curran. Let's go back to you.
Okay, I got a doctor's appointment coming up, I think on the 11th or 14th, and I got the wrong map. calendar up. Anyway, soon, and I'm thinking doctor may put me over on Xtandi, and I heard there's only about a 15% chance that it would do much good if you had failed Zytiga, and I was wondering if anybody else had heard that.
Oh, you've already failed Zytiga?
Yeah, my PSA has been doubling every 2.5 months.
And how long were you?
I was on Firmagon too, and before that Luprin, but I started Zytiga in February. I'm still on Firmagon.
Still on Zytiga, but the PSA is rising.
Yeah.
And he wants to switch you to Xtandi. But what percentage did he give you?
I had just heard in another support group that it was about 15% chance.
15. Yeah, that's about what I've heard too.
Okay.
I think the most common resistance mechanism with Zytiga as well as Xtandi is the ARV7 splice variant. But did he talk about testing you for that?
No, he's aware that I had a thing called the California 500, which they do at UCSF in San Francisco.
Right.
So he knows I've had that genetic or genomic test, whatever it's called.
Yeah. Did you have any actionable genes?
No. There was a slight hint one might be actionable, but it wasn't a full-fledged guarantee.
I think the test you're talking about, Jay, is different than the ARV7.
Oh, okay.
Yeah, ARV7 is not normally tested for in the genetic profiles.
Right.
The mutation profiles. Let's see. What about Provenge? Have you tried that?
Yeah, I tried that, and during the process of doing that, which takes about a month or so, it rose from about, I don't know, 2 or 4, something like that, up to 101. And
wow.
then
A month?
And then on Zytiga, it came back down in about 5 weeks to 4.9.
0.19. No, that's good. And where is it right now?
About 13.
13.
Yeah, I'm going to let these guys keep going and run the meeting today, and I'll just chime in. The Provenge wouldn't have anything to do with that, I doubt. And first of all, Provenge takes an awful long time to have an effect. And I can't see how that could be attributable. Did you not finish the Provenge?
No, I did finish it.
Okay.
No, I didn't mean to say that that would cause his PSA to rise.
No, I didn't hear you say that.
Yeah. Okay.
I heard, that's what I thought Jay was suggesting, because he said when he did the Provenge, his PSA rocketed.
And Jay, have they?
Then it went down on the Zytiga. He tried the Provenge before he tried the Zytiga, and it went from 100 something to down to about 4.9 on the Zytiga. But now that is apparently not working any longer. It's gone up to 13.9. Did you say, Jay?
Actually, it's 12.7.
12.7. And they're talking about starting Xtandi.
Yeah, no, I heard that.
Oh, you heard that part? Are you familiar with the 15% number that Jay mentioned, Rick?
Yeah, I think it's probably in the ballpark, as Len said.
Okay. So I guess the question for Jay is, should he try the Xtandi, try to get approval for that, or should he go and try the ARV7 test first? which would be the better way to go. I don't know.
Well, I doubt that he's ARV7 positive. Otherwise, he wouldn't have gotten as much time out of Zytiga as he did.
Okay.
How long were you on the Zytiga?
From February 5th.
Until now?
I'm still on it.
Okay. And the fact is that it's clearly keeping your PSA at a low level. It brought it down from 100 on 1, and yes, it's creeping up. But how quickly are you doubling right now?
About 2.5 months.
And what does Agarwal say to you?
Well, what he said was he takes 3 things into account. He takes symptoms, scans, and PSA. And I just had my scans, and I tried to read them myself, and it looks like there's not much progression, but who am I to say? You know, I'm just a layman.
Okay, but what is Agarwal saying to you?
I'll see him on a week from Tuesday.
So what's your question for us?
Has anybody else heard of that low figure of Xandy helping once you failed Zytiga?
Yeah, I mean, I think the numbers that I've heard, I'm not certain, I really don't recall, is around 30%.
30.
Yeah, it's what I've heard also.
30, did you say?
20.
15. Didn't you say 15, Rick?
No, I said I think the number that I've heard is around 20%, but 15% is close enough for government work.
Right.
No offense intended.
Yeah, to us ex-federal employees. Thank you very much.
So, you know, I guess, so to come back to you, Jay, I mean, what, is that what you're asking us? Is Xtandi likely to be effective in 20% of the time?
Yeah.
So, you know, I think the bigger question is, if I were in your shoes, is how long do I stay on abiraterone, not should I change? Because, you know, you're not going up that quickly, and you want to get the most out of every sector, wouldn't you say, Len? Len, I don't want to jump in and moderate this meeting. I'm very happy to let you do it.
Yeah, no, I don't mind at all, Rick. Just feel free to jump in at any time.
Thanks.
All I can tell you, Jay, is that if it were me, 15% is better than 0%. I'd give it a try. It sounds like while you're on Zytiga, you just jumped up to 12.7 from, I'm not sure how low. I thought you said 0.19, but
no, 4.9.
4.9. Okay.
That was my nadar.
Yeah. I'd give it a shot, as long as you have good insurance and you're not paying $8,000 a month.
Yeah. I think I asked this. Go ahead.
I was just going to say, I kind of agree with Rick. I would stick, if it was me, I would stick with his Zytiga a little bit longer, because it is still pretty low. And if you're not having symptoms, you know, let it run its course. And then when the time comes, then try the Xtandi. That would be if it was me, that's probably what I would do.
Any thoughts on that new one that's like Xtandi or apalutamide?
Apalutamide or Lita?
Yeah, it does not cross the blood-brain barrier, supposedly, so less chance of a stroke, maybe.
Has anybody on this call ever used apalutamide that we have?
Yes, Jay Kruckman. How are you doing on it, Jay?
Okay.
I am on it. This is my second time on hormone treatment. First time was just Firmagon and Lupron. That was about 18 months ago. And I just went back on 5 months ago with Lupron or Firmagon and Erlita, which is at the epalutamide. I haven't had as serious side effects as the first time around, even with the addition of the apalutamide. My PSA has not gone down as quickly as I would have thought it would with both the Firmagon and Erlita, but I mean it's very low. It's gone very low, so I don't think there's any additional side effects, and can't tell you if it's worked better or not with the addition of it, but it hasn't. I don't think it's hurt me in regards to side effects. That's for sure.
Mm-hmm.
Had you ever been on Zytiga or Xtandi previous to that, Jay? Jay?
No, I've not.
Okay. So you're a little bit different than Jay Curran.
Yes.
Jay Curran, did Agarwal discuss any other options for you besides Xtandi?
Well, I kind of forced the issue on LU-177, and he said, well, there's going to be a study at UCSF, but I've been hearing that for a year and a half.
So the only thing he's proposing is Xtandi.
Yeah, and he actually hasn't done that yet. He just said, we'll watch those symptoms and look at the scans, which he hasn't seen yet, and see what my symptoms are. He said, watch my blood pressure.
So what's your inclination? Is your inclination to switch to something new, or is it to stay on Zytiga, or is it to do something completely different?
Well, I think I would want to try LU-177.
And why? How extensive are your mets?
They're diffuse to the bone.
Right. But how extensive are they?
Well, diffuse. There's more than 5 for sure.
How extensive
spinal.
are they? I mean, do you have them in your pelvis, your hips, your ribs, your spine? How extensive are they?
Yeah, they would be everywhere. Maybe not the ribs, but everywhere else.
Okay, so you have multiple lesions in your femur, in your pelvis, in your spine.
Yeah.
Anywhere else? Did I miss?
Well, there's one in my head, but they don't ever talk about that very much.
Right. That's important though to mention.
Okay. Okay.
I mean, what I'm trying to figure out, and the discussion that I would have with Agarwal is whether you're a candidate for LU-177 now, or whether it's something that's worth holding on to. And I certainly wouldn't know that, but he ought to have an opinion as to whether it's something you should do now. I mean, there are studies that you can get into at very low cost, if any cost. Nordquist is running one in Omaha, and what's his name in Phoenix is running one.
Almeida.
Almeida's running one in Phoenix, and we've talked about that on these calls several times, especially the Almeida one. He's now into his second year, his second cohort.
They said they'd call me in September, into September. Phoenix Molecular.
Right. So he's into his second cohort, and if you show up at PCRI, you can talk to him directly.
Yeah, I'm going down there. All goes well.
Oh,
What
what
about
part
radium
of the
223? If the Mets are confined to your bones, why not? What about radium 223?
Well, because lutetium is a better option than the radium 223.
Is that replacing the radium 223 pretty much?
Well, it's not readily available, and the Bayer would not agree with that, which is going to be, I think Len's going to be in a position to give Bayer some feedback on Friday morning. I wish I was, but Len, by the way, if I forget to mention it to you, they changed their mind and they want to include me, which has happened before. Send me a text or call me and I'll come into that meeting. But I feel quite strongly about this. I mean, Xofigo has got to show that it is more effective than lutetium-177 because we know that the side effects of the Xofigo are probably worse and at best about the same. That's anecdotally from men that we've seen take it, and I don't know that they've ever been compared in a head-to-head study, but the big benefit of the lutetium is that it's sensitized to the prostate-specific membrane antigen and not sensitized to calcium in general.
Mm-hmm.
Right.
And I'm sure you'll make that point to them. Why would anybody want to do Xofigo if they can do lutetium-177?
Well, as I understand it, Rick, it's kind of a survey that they're asking me to partake in, and it's about a new medication. Definitely not Xofigo.
Okay.
It's something still in. Alex Schultz said phase 2 or 3 clinical trials. Yeah.
Okay. My guess is that whilst you're there, they'll be asking you about Xofigo, but we'll see.
Yeah, they may. Although I'm not on it, I've never been on it, so I don't know how much they're interested in talking to me about that.
Yeah, but again, we hear a lot of feedback from men who have been on it. And so by talking to support group leaders, they get valuable information.
Yeah.
And as support group leaders today, at least in our group, I don't know who would recommend lutetium-170, who would recommend Xofigo, radium-223 over lutetium-177.
Yeah, I'd agree with you there. The few people that I know who have been on Xofigo, it's unclear what the benefits were, but it's for certain that it was causing bone marrow suppression, which is not a good thing.
Now, that isn't to say that lutetium is going to leave you free of myelosuppression as well. I doubt that it will. And certainly Rob, God rest his soul, suffered some myelosuppression from the lutetium. But we also saw he got a huge benefit out of it too.
Yeah, right.
So, Jay, your discussion with Agarwal is probably going to, well, first of all, second-line anti-androgens are not mutually exclusive of doing a radionuclide drug. So there's no reason why both couldn't be done at the same time. But, the issue is, do you stick with your Zytiga? Do you stick with your Zytiga and add a radionuclide drug? Or do you just do a radionuclide drug? These are all questions that I would be asking my medical team to see what they think are the best options for me right now. Unless I had a strong opinion myself based on good evidence.
Yeah, I agree with Rick there, Jay. Ask Agarwal to give you a full list of your options at this point, and ask him what his best recommendation is. And I mean, hopefully he's the kind of guy that says it's a mutual decision and he lets you decide. If you choose to do something other than what he's recommending, have him try to convince you otherwise. So at least you know what the benefit risk ratios are for each of the options that you have. I mean, if he tells you to continue on Zytiga, being that I think you said you're asymptomatic, I would ask him what are the risks for continuing to do that. If as you said, you have extensive meds, to continue on a medication that appears to be no longer working is not something that would make me comfortable.
Yeah.
Time is of the essence, I would think.
I don't know if this has any bearing on it, but he wanted me to ask my dentist if I could go on something that would coat my bones. He said, I forget the name of that.
Oh yeah, the bisphosphonates, the Zometa, or right.
Yeah, you know, it's beyond me, to be honest, why they don't put men on these on 5 years ago. Everybody was being put on Zometa or denosumab. What's the other one called, gents? Denosumab is the generic name.
Yeah.
Zometa or
I forget myself.
I can't think of it either.
It starts
Exgiva.
Yeah, I knew it started with an X. Everybody was one or the other. Now they don't want to do this anymore, and I don't get why. I mean, Jake has been on Zometa for donkey's years, right, Jake?
6 years, yeah. 6 years in June.
6 years.
Yeah.
I mean, the issue around the Zometa is how often you should get it. It's certainly not as often as we used to think. But this is not a new drug, Jay. This is a drug that was 5 years ago. It was a standard. You had Mets, you went on Zometa. And it just seems like they don't want to do that anymore. And I don't get why, because it's a prophylactic drug. It prevents the cancer from either spreading or getting into your bones.
Well, you mentioned necrosis of the jaw.
Yeah, but the incidence is about 1 or 2%.
Okay.
And that's been the same forever.
Okay.
And we've talked about that on this call numerous times.
It's Larry. I just want to add that my dentist and others have said that it's more like 20 or 30%, and some reason it's not being properly recorded or tracked. And she asked me to try to avoid it, and my doctor didn't agree, but my doctor at Sloan agrees.
Well,
so I just for the
I
heterodox opinion.
I appreciate your input, but it's not documented as such. And I've known 2 guys in all the years we've been doing this who have been on Zometa who have had issues. Eric, and there was one other guy. I think our friend in Idaho, he had problems with his jaw.
Kelly?
Yeah, Frank Kelly had problems with his jaw. Maybe one more person. But, we probably talked to 100 people. So I just don't know. That means 3 out of 10 people, and this is purely anecdotal, but it's never been our experience, and it concerns me why, if that is the number, it isn't more better publicized.
All I can do is use myself as an example. I've been on it 6 years. I haven't lost any teeth. Knock on wood. But my oncologist swears by it. She says it's very important. It's necessary. So it's certainly worth considering. And denosumab is supposedly a little bit better.
Yeah.
A little bit less side effects and a little bit more effective. So.
I mean, Larry, is she just giving you an anecdotal opinion? Is this the lady? Is this the one of the people from the dental group at Memorial Sloan Kettering?
No, it was my personal dentist, and she'd had experience. But to go further, I saw Dr. Kantoff at Brigham Young. I mean, at Dana-Farber.
Yeah.
And he said you should get a bone density scan, and if there's no evidence of, or doesn't look like there's any kind of fracture risk, then you should hold off. Suggest that I hold off until it seems that there was a reason to add something to my treatment. So that was a second that, and then I went out of it. That was what made the final decision for me.
All right. Well, I got Zometa. I got 3 infusions of Zometa because I had bad bone density and because I was being placed on long-term LHRH.
Yeah, I understand that decision, and I think bone density is one consideration, and the other is the other thing that you're talking about is the doctor who's suggesting you get a shot every month or every 3 months. You could just opt to take a few shots or every 6 months.
Right.
And that seems like a reasonable option.
Right. I mean, we now know that 6 weeks, which was the original protocol, is no worse than 3 months. And my guess is that you could probably push that out even further. And by the way, this drug is not just used for prostate cancer. It's used for breast cancer, and it's used for other cancers where the disease goes quickly to the bone.
Right. It has to do with bone turnover. The ADT causes your bones to the osteoblasts and osteoclasts, whichever which is one or whatever. But it has to do with turnover, and the Zometa helps keep that in balance. And I haven't had any bone fractures in 6 years either. So for what it's worth. I guess I'm a poster boy for Zometa. They ought to be paying me to take this shit. I ought to call them and ask them to put me on their mailing list for a check every month. I don't know.
But anyway, I can only tell you that if it was me, I would be taking that. At what frequency I cannot tell you, but I would take a bone strengthener in a heartbeat. It does 2 things. It makes the bone more slick, so it's harder for the cancer to grab onto it. So that's preventative. And it makes the bone more dense, so it's harder for the cancer to spread. If it's in the bone. And I can only tell you based on what I know what I would do, and I would definitely be including it as part of my treatment. Does it cause or is it highly correlated with ONJ? Yeah, it is. But how frequently, as you've heard Larry and me discuss, the numbers say 2 to 3%. Some people think it's higher than that, but I have never seen any numbers that show that it's higher than that. So everybody.
The highest I ever saw, Rick, was 7.5, and that was after like a good number of years. The longer you're on it, the more likely you are to have side effects.
Right.
But even then, it was like 7.5%. I never saw 20 or 30%.
Yeah.
And I do try to pay attention to it because I know it's there are issues with it.
Well, like Larry said, people aren't publishing, but I would put more weight with the dentist who's seeing patients, actually seeing ONJ in that dentist's practice. And that dentist may not be publishing the data, but...
Yeah, but Len, how do you know how many people are taking it versus how many she's seeing?
I don't know.
She's always going to see the she's going to see the patients. She may see 10 patients, but if you look at her her capture area, there may be 10,000 people taking Zometa. She has no idea. That's the problem. I mean, you can't base it on. It's like going to the Memorial Sloan Kettering actually has an oncological dental group.
Right.
Food is used. Right. Now, if you ask them, they're going to say, yeah, we see loads of people with ONJ. Why? Because anybody who's got ONJ is referred to them and they see them. But that doesn't relate to how many people are taking the drug. Do you see what I'm saying, Len?
I understand what you're saying, but I'm just thinking that a dentist will have a sense that the percentage is higher than what they see reported, and therefore they'll talk to other dentists. And are you seeing more ONJ than what's being reported in the literature? And I'm assuming that's how Larry's dentist came to this conclusion. I kind of doubt that she would just keep that information to herself and not talk about it with other dentists. But in any case,
kind of like a car. You only take your car to the dealer when you have a problem. If your car's running fine and smooth, generally you're not going to take it into the car dealer. And it's kind of like, that's what Rick's talking about. It's the same kind of thing. People only go to the dentist when they have an issue.
It seems
no, people go to the dentist for not just for ONJ. They go to the dentist for cavities, for God knows what. But what I'm thinking is the dentist is aware. I know my dentist knows what prostate medications I'm taking, and I'm sure Larry's dentist knows. So he or she has an idea of how many of her patients are taking these types of drugs, the bisphosphonates or the Xgevas, and has some record of how many patients are getting ONJ. Anyway, I'm not trying to dissuade Jay Curran from doing it. I actually think he should, because as Jake mentioned, the incidence of ONJ increases over time. So if Jay just starts it now, he should be fine for years.
Yeah, let me just weigh in for just one more minute. That after I was diagnosed, and my first oncologist said, okay, I want you to do radiation for your hip and Xgeva for your bone stability to avoid fractures. Then I saw my dentist who said, in her experience, there can be a lot of problems. She feels that in the network of people she talks to, that it was, if you didn't really need it, try to avoid it if you could, but I didn't make a decision. Then I saw that the doctor at Dana-Farber who said, well, why don't you get a bone scan and see the bone scan results? And if bone scan looks normal, why don't you follow that and hold off? And at that time, it's like Rick is saying they were, my doctor was saying like every 6 weeks or something like that. And it seems like it's pretty reasonable to go every 6 months for a while and see if any problems develop, but I don't know if those problems are reversible. I think a bone scan is a great idea to start with. I mean, bone density scans is a great idea to start with, and definitely if there's a bone density issue of any kind, then I would say I would be absolutely supportive of Jay taking it. And if there's no bone density, then I think it's a toss-up, or maybe take it once every 6 months or something like that, like Rick is talking about.
But it's, that raises a really good issue, Larry, and I'm really pleased that you stressed the point. Every man who's on long-term Lupron, LHRH, any type of LHRH, Lupron, Firmagon, Trelstar, whatever it is, should be getting a bone test once a year. And the docs don't order it because there's a very high risk of losing bone density. And it bothers me personally that they don't run these tests and men don't ask for them. It's interesting. I tripped and fell when I was in England, and I'm pretty certain, I'm 95% sure that I cracked a rib. And I was staying with close friends who were docs and whose daughter and son-in-law are training to be orthopedic docs. And the wife, they're both involved with breast cancer, my friends. And the wife said to me, when was the last time you had your bone density checked? And I realized that I haven't had my bone density checked for about 5 years now. And, all men should check their bone density from time to time, but especially if you're on these drugs. Tell your doc, I want a bone density test. They need to be repeated every 2 to 3 years normally, but if you're on these drugs, probably once a year, and find out if your bone density is low.
I agree.
Who on this call has had a bone density test in the last 24 months?
This is Dennis.
I
I have.
have.
John Appler.
Okay, John Appler has. And
Jeff
John, you were diagnosed within the last 18 months, correct?
Yes.
Right. So, that was probably a good medical team making sure you didn't have any issues before they put you onto Lupron. Have you been checked since you went on the Lupron?
Yes, 1 year anniversary, and I'm just going to get the results back any day now.
Fantastic. So that's how it should be. Dennis, tell us what your history with bone density is.
Yeah, I had one done as a baseline before I started any treatments. The recommendation of the oncologist, so they had something to measure against, and also to see what kind of risk I was at. And then the schedule is I'm on every 2 years. So I've fairly recently, let's see, probably in the spring, I think it was, when I had my last one, and there was no changes from my baseline.
Great. And Jeff Marchi, what's your history with bone density?
Mine was just short of about 18 months ago. Before I started Lupron full time, they had me to run a full set of tests. So they haven't done it since, and I don't know. I will check about whether I should have it, and under their guidelines as well. I mean, it sounds like I should anyway because, of other issues. So,
well, I was a Kaiser patient, and I did have low bone density initially, and they put me on Zometa, but they tested me annually to check. So, I'd be asking for a test. And if they say, oh, you don't need to do it that often, you say, well, but what about the fact that I'm on Lupron?
I agree. I will ask. And they've been pretty darn, as I'll speak about later, they've been pretty good at coming up with things.
Okay. But, we've got other guys on this call. And Len, when was the last time you did a bone density test? Oh, mind you, you're on holiday right now.
I am, but I definitely should have had one by now. I haven't had one in 3 years, and I had tried to schedule one a year ago, and then they canceled it on me, and somehow it never got rescheduled. But I do have an appointment with my primary care provider in about 2 weeks, and I'm going to ask them to order it.
I think I've made the point. How about? Okay, I've made the point. We don't need to belabor it. Back to you, Len.
Jay, have we thoroughly confused you by now, or?
No, it's been enlightening.
Okay.
And if there's time after, if everybody else is gone, I got another question. It's kind of a short one.
Well, sure. Go ahead right now.
All right. This is what happened. I was talking to a bio scientist today, and I told him I had low sodium, and he said I had a friend. He had a friend that had low sodium, and it kind of did him in. I guess it had something to do with calcium. But I'm sure my doctor's aware of that. Has anybody else had a problem with having low sodium causing problems?
How low was it, Jay?
Well, it's kind of like borderline at the bottom of the range.
Well, what about your other measures of kidney function, like BUN, creatinine, things like that? Are they normal?
I believe so. There are certain things that are low, and they said they would be low, like red blood count and white blood count, and things like that.
All right. Well, Agarwal monitors these things for you, right? I think.
Yeah. He just started with me a month ago. So,
oh, yeah.
So I imagine he has been.
You can raise the issue with him, but it's probably not worrisome.
Okay.
You may have just been a little overhydrated at the time, so your sodium was a little low.
You mean like drinking too many glasses of water, or not enough? Okay. All right.
Yeah, if it's just borderline low, like just below the reference range, I wouldn't worry about it too much, but definitely mention it to him.
Okay.
All right. Rick, we had Jeff Markey wanted to take some time tonight, so he's next up at that. Go ahead, Jeff.
Well, hello there. As you know, I've had a real problem with hot flashes for quite a while. And after 3 months or 2 months, they'd finally, the 6-month shot, they'd finally settled down a little bit. But I also started having a problem in March where I just could not walk well. I could not walk up my front steps without walking one step at a time. I'm 70. I'm in pretty damn good shape. I am not an ounce overweight. I could not stand on my right leg more than a few seconds. The weakness was sporadic. I looked on the web, found it was common with Lupron. I went to a PT at Kaiser, did leg exercises for 2 months with stronger and stronger elastic, built up the number of reps I was doing, built up my leg muscles, and I can stand on them longer. But I go to dinner with friends. We're in a booth. I get up from the booth. I can barely move. It's like I'm a cripple. it takes me 20, 30 seconds before I can walk. I sit down, it's the same thing again. The next day, besides that, I have 2 hot flashes during dinner, need cold water and a fan to keep myself cooled off. Well, then the friends called and said, "Does Jeff got much longer?" At that point, I called Harstark at Kaiser because I think I'd done about all I could do. And she says to me, "Okay, let's go with a Depo-Provera shot." And she looked through the medicines I was taking and found out I was taking Lipitor. I didn't need Lipitor because my cholesterol was fine. But my doctor had a recommendation from Kaiser that if you're 70 years old, then you should take Lipitor especially if you have AFib problem because for your heart. Well, at that moment, I said I will stop taking Lipitor. 3 days later, I could walk. 3 days later, I could move. It's about a week after that, and I mean, I have so much more mobility. It is incredible. I mean, my right knee is pretty bad from arthritis, but I can get it on my assault bike and go for 5 minutes 4 times a day. I had stopped being able to walk on the treadmill. I couldn't do it. Now I can do it again. The Depo-Provera shot, I had it on August 21st. By the 23rd, I started having flashes on a regular basis every hour and a half to 2 hours. It was lovely. By the 26th, 5 days later, I was having even more frequently, but the frequency didn't change much. They seemed, I thought, to be milder. By the 30th, which was 9 days later, I noticed I was hardly getting any flashes at all. And today, I think it's been about 5 hours since the last one. The Depo-Provera, while they give you double what they give a woman for birth control, they said it probably will only last a month. And it really, I mean, between being able to walk and not having the hot flashes, or if I get one, because I get them a little bit, just a little bit of cold water and maybe a light bit of fanning, and I'm fine. I don't start sweating. I don't get heavy sweats. Just a couple things to think about. I thought I'd let everybody know. Fortunately, my PSA, I had a test a couple days ago, and it's still staying at less than 0.01. So my 3rd time through, I'm staying okay with Lipitor. Oh, by the way, they're also, at your recommendation, she's switching me to the 3-month shot when I get my next shot instead of the 6-month. And instead of getting it immediately after 6 months, I'm going to get it 2 weeks later because I know damn well my testosterone doesn't start going down for at least a month. I've had a test last time. And maybe that will at least reduce the amount of time for which I'm going to have those hot flashes.
Okay. Well, it's good news about the Lipitor. Valuable information, I'm sure. We'll have to keep that in mind.
I thought that might be.
Yeah.
What was your name again, sir?
Jeff Markey. I also live in San Francisco, so fortunately the cold weather here all year has made it very easy for me to stay cool. We haven't had a day over 70 yet, I don't think.
So
that ocean breeze comes up at 3 o'clock in the afternoon.
Yeah, I mean, Lipitor is associated with muscle issues, and it's reported. It's pretty widely known. I mean, we don't talk about it as much. I honestly don't. I don't think Crestor is, and Crestor seems to be the drug of choice for statin and prostate cancer. I mean, if it was felt that you needed to be on a statin, and it's probably a good idea to be on a statin when you're on long-term LHRH, and I would certainly.
I do have low cholesterol, so the statin wasn't necessary for cholesterol.
The problem is that the LHRH drugs do cause metabolic side effects, and so that's the reason why it's thought to be a good idea, but in your case, it might not be necessary. But you know, I don't know what whether Crestor. I'm just looking at it as we speak, and I don't know if Crestor. I mean, it does cause weakness. It doesn't cause or tired feeling. Certainly, it doesn't do that for me. Because I'm on Crestor now. I used to be on Simvastatin. You know, everybody's.
I was only put on this because when they look at the computer, there was a yellow thing that said it might be good for me, even though I had low cholesterol because I was over 70. There was no other reason I actually needed it I didn't need a statin for cholesterol. Is there some reason that you know of that it would
Yes.
be useful for?
Yeah, because you're on an LHRH drug, as I said. Because you're on an LHRH drug, it's probably a good idea. Len, you want to comment on that?
I'm sorry, Rick. Could you just repeat that? I was trying to find out why. I remember Snuffy preferred Crestor to the other statins. I was trying to find out why.
Oh, the reason is because it doesn't interfere with as many pathways as the other drugs do.
Okay. And so what was your question to me?
And my question to you was whether you have any thoughts on whether somebody on an LHRH drug should be taking a statin or not.
Well, the conventional wisdom now seems to be that yes, they should. However, as we just learned from Jeff, although as Rick has mentioned, it was fairly well known, the side effects just not quite as severe as what Jeff experienced. So, you know, if you can take a statin and you have no side effects, sure, why not? But you know, if it's affecting your quality of life, then especially for someone like Jeff, who's got an almost undetectable PSA, I wouldn't think it would be necessary for him.
What's the reason for needing a statin?
Just because it's recommended at my age by the medical community. Maybe they can sell the drug and make more money, but I doubt that because it's very inexpensive.
I'm not sure of your question, Paul. Were you asking what is the reason why men over 70 are put on a statin, or what is the reason why statins are recommended if you are on an LHRH drug?
Yeah, the second one. You said if you're on an LHRH like Lupron, you should be on a statin. Why?
Right.
Len, do you want to address that?
Well, I think that the reason some oncologists like to put their patients on statins is because there is some evidence that it does have anti-cancer properties. So it doesn't, I don't think it's necessarily correlated with whether or not you're taking any hormone drug. I think, although as Rick mentioned earlier, taking the hormone drugs can upset your metabolic, what do they call it? Metabolic syndrome, where your cholesterol increases. And of course, statins bring down your cholesterol levels. But it's believed, although not definitively proved, that statins have anti-cancer properties in patients. They've done retrospective studies showing that prostate cancer patients on statins prior to diagnosis seem to have better overall survival. So I think that answers your question, Paul.
For me, the statin was recommended by my GP under my annual physical in 2017. and it was just one of the things that they pop up on the record. So it had nothing to do with the cancer diagnosis in my case. I just thought I'd mention that.
Yeah.
But and I get that. I get that. But there's a lot of literature on the impact of LHRH drugs on metabolic syndrome, which is a shorthand for how likely you are to have a heart attack. And there's been recent stuff, which I think I have linked, but I just put one article in the chat window right now that people can link on. But if you want to examine it more, just Google LHRH drugs and metabolic syndrome, and you'll come up with a lot of clinical articles, clinical research. And so we know that when you are on long-term LHRH drugs and you have no testosterone in your body, you're likely to put on weight, you're likely to waste muscle mass, you're likely to increase your cholesterol, you're likely to, what was the other one that just went through, oh, you're likely to increase glucose. And all of these are...
What was the last one?
Glucose, increased glucose.
Okay.
Blood sugar.
And all of these are associated with an increased risk of metabolic syndrome and an increased risk of cardiovascular disease. So the reason why they put you on this is because it lowers your metabolic syndrome risk. I'm not giving advice, I'm just stating the research. So for me, I would be talking to my docs and asking them, do you think that being on LHRH drugs increases my metabolic syndrome risk, increases the risk of cardiovascular disease? And if it does, what can I do about it? And you're likely to hear things like diet, exercise, for sure, statins, possibly metformin. And these are the reasons why people like Snuffy Myers years ago recommended Crestor and recommended metformin.
Right, Jay, I just recalling now the theory behind how statins might have anti-cancer properties, particularly in castrate-resistant prostate cancer, is that when the cancer is still growing in the presence of very low testosterone, the cancer cells will pick up cholesterol as a precursor for synthesizing its own testosterone to feed the cancer growth. Now, statins compete with cholesterol, the cholesterol cell receptor. And so they believe that to the extent that there is a valid anti-cancer property to the statin, it's because of this what they call competitive blocking of the receptor. So the receptor is picking, instead of cholesterol, it's picking up a statin, and the cell can't manufacture testosterone from a statin, only from the cholesterol.
So are there statins that can be taken that will not have the same problem with muscle weakness?
Well, I think Crestor is probably a lot better than Lipitor. Lipitor is known to cause problems.
You mentioned that. I wrote it down.
Right. So, as I said earlier on, I also mentioned that Crestor is a better option and it doesn't cause as serious a problem. And there may be others, but I think that it's not so much you telling your doctor, I want to go on this statin or that statin. It's you having the discussion with someone like Andrea rather than your PCP, because your PCP may not be an expert on the impact of LHRH drugs. So you're better off talking to Andrea and saying, Andrea, I come up, you took me off the Lipitor, Dr. Hartstock. Do you think it would be good to try a different one, maybe a low dose of a different one from the standpoint of metabolic syndrome to protect me? Or do you think that that's not necessary? That's the conversation. We can't tell you what to do, but we can say to you, this is the conversation you need to have with your doctor. And you know, as you know, Jeff, I have a huge amount of respect for Andrea. So if she says, don't worry about it, I'd say fine. Would it stop me giving the same recommendation to somebody else to discuss it with their doctor? It wouldn't, because every doctor has their own opinion. But at the same time, I think it is a conversation that everybody who's on long-term LHRH drugs, androgen deprivation therapy, should be having with their dog.
And up until about a year ago, Crestor was very, very expensive, but it has now since gone generic.
Right.
So it's similar in a price range. It's similar to Lipitor or Simvastatin, some of the other ones. Almost all of them now are been around so long, they're all generic and they cost a couple dollars a month. So,
well, my wife can take my remaining Lipitor. I'll try that out. I'll check with Dr. Hartstock for sure. It's good to know. I mean, this is really, the doctor had said there were heart issues that were directly related to why you wanted to take it. But he has nothing to do with the oncology department. So this was really, you know, out of the blue recommendation. Thank you very much. I really appreciate it.
Thank you, Jeff.
Could I just make a comment, Jeff? This is Dennis Correa. I had a similar issue with my legs after being on Lupron, after I started Lupron. Sounded very similar to your situation. Either get out of the car, you wouldn't be able to move or stand up, you felt, or get up from a table. And what worked for me, I guess it was a side effect that when I had to go on the Zytiga, which meant I needed prednisone. And boy, it wasn't long after that prednisone that whole leg issue just disappeared. So I don't know if you had any other changes in your care or whatever around that same time. But for me, I know what resolved that issue for me, and it was when I went on Zytiga with the prednisone.
Interesting. I unfortunately, I don't think I'm at the point I need to start taking that, but thank you.
Okay.
Yeah, I'm going to talk to my doctor about Lipitor too. I've been on it for a number of years, long before I had prostate cancer, and I also have some leg problems, you know, weaknesses, and I assumed it was from the Xtandi, but it might be a cumulative effect of the Lipitor. Maybe it's time to try Crestor.
3 days off the Lipitor, I stopped the problem. Went away dramatically. I did have dizziness for a couple of days, and I couldn't do my floor exercises, but that was all from stopping Lipitor after a year and a half.
Oh, really? Huh. That's interesting.
So Jake, you're gonna
Yes,
have to you're gonna have to give a break to those floor exercises.
Yeah, I'm really sorry to hear that.
Breaks your heart, huh?
It does. I'm heartbroken now. Jeez, thanks for ruining my day, Rick.
Hey,
All right.
I could barely walk. Doing exercises got me back, so I'm still doing them. Sorry.
Well, I'm afraid to stop mine because I do need it. Because I do have high cholesterol. You know, but so I can't stop it completely like you did. But maybe changing to a different brand might be the solution.
Right.
I think the thing you're talking about is isn't it Rhabdo? It's Rhabdo something, RHAB.
Yes. Yeah. It is. It is. Because I just saw that when I looked.
Rhabdomyolysis,
Yeah.
Thank you. Thank you.
muscle weakening. Yeah.
But one other thing I do want to mention to you, Jeff, is that you may not recall, but when you first started talking about your hot flashes, I think I sent you a paper by Chuck, what's his name, the old boy, then.
Yeah, the acupuncture tape you're talking about, is that what you're referring to? Which looked pretty positive.
Yeah, about Depo-Provera. I sent you a paper on Depo-Provera. Do you remember that?
No, I do not. That must have been at the very beginning.
It was.
Yeah,
we talked about acupuncture, but I also sent you because the Megace is what's often used, but there are risks with Megace, and this old time advocate, he doesn't show up that much anymore. You know what I'm talking about?
Chuck Mack?
Chuck Mack, thank you. Yeah. He wrote a paper on Depo-Provera, which I often send out to people, where he recommends Depo-Provera and shows all of the research. And so we always tell.
I will find it.
Megace, Depo-Provera, what have you. I mean, you don't need it now because you're getting it, but I think I wonder if I've got it linked on a PDF.
I'll find the email you sent me. I never lose email. But I'm wondering, do you know how long it lasts? I was told by the nurse that gave it to me that for women, while it lasts 3 months, for men, it only lasts about a month, she thought. She wasn't sure. And since it took 9 days to really get in there, do you have any idea on that?
I don't, because unless he addressed it, and it's years since I'm ashamed to say I haven't actually read it, but I have it here. I'm just pulling it up. Let's just see. Hot flashes. Let me just see. Let me sure. It's either under Chuck Mack or it's under hot flashes.
I figured I could live with it for a little while. That was why I didn't pursue it immediately, but after months, it was enough.
Bear with me 1 second, because I know that we have this. Hot flashes, Chuck Mack. Okay, I'm going to post the URL in the chat window right now. There you go. I've got to send it to everyone, not just. There you go. So so you don't need to look for anything. There it is again. And there in that he talks about the impact of Depo-Provera. Okay.
Great.
Back to you, Len.
All right. We're going to move on now to Paul Frieda.
Okay. Yeah, I just have an update. My doctor and I have agreed to stop Lupron now. It's in November, it'll be 3 years. And so he thinks it's probably a good idea for us to try stopping it. And so, a little bit nervous about that, but he seems to think that I should be okay for a year or so, maybe more. And now, when it comes back, would I go back on Lupron, or would I don't know? Can anybody tell me that? No. When my PSA starts to rise again, would I immediately jump back on Lupron?
The answer is yes.
Yeah.
Right. Okay. All right.
In fact, you might find that it's more, well, in my case, you know, it was very effective. It worked almost immediately. I got off it for about 8 months, and my PSA started rising, and I went back on the Lupron, and boom, it was back down to the old levels.
Right. Uh-huh. Okay.
And hopefully you'll get more out of it than 8 months.
Yeah. Well, we'll see. The other thing I would mention is that when I went for my Lupron shot, they wanted to switch me over to Firmagon, and I said to them, look, you know, this is my last shot, so I really don't want to switch drugs. And they said, okay, and they went and found a Lupron injection. But I'm wondering if that's going to be a general trend in the industry where they're converting you from Lupron to Firmagon, or is that just specific to my particular oncologist office?
Well, Paul, chances are, if you're talking to your doctor about stopping Lupron, Lupron is usually a longer lasting formulation, 3 months, 4 months, 6 months. Firmagon is once every month, so maybe they're thinking it'll wear off faster. If you're going to drop LHRH completely, most likely they want you to, you know, they figure, well, we'll just do it for a month and then it'll drop off sooner than the Lupron would.
Oh. Well, he didn't tell me anything about that there was a reason that they might want to do that. But anyway, I got the Lupron shot, and so
being cynical here, Paul. One reason they might want to do that is because, at least in my case, they charged $780 for each injection.
Oh.
And that doesn't include the drug. That's just for the administrative fee of injection of the drug. $780 every month.
So they make more money with monthly injections, huh?
For sure. And the other thing you should know, if you don't already know, is most people, not all, but most people get painful injection site reactions.
With Firmagon?
With Firmagon. It's a shot to the gut, to your belly, in the belly fat. And in my case, and in most cases, it causes swelling, erythema, which is a redness, tenderness, and it can last anywhere from 24 hours to 72 hours or even longer.
Wow.
So it could be pretty uncomfortable. You might be one of the luckier ones who has a much milder reaction.
Well, I didn't get the Firmagon. I got the Lupron. So.
Right.
Yeah. So yeah.
Okay. Yeah, I had that same reaction to the Firmagon. Got swelling. I had like a half a tennis ball look underneath my skin. That's where it swelled up, and it's right around the waistline. So then you got to find something when you put on a pair of shorts or something. You don't want that elastic waistband on there.
Right. Yeah. Yeah. Well, so anyway, that's what's new with me.
Two things. One is that in defense of Firmagon, it's probably a better drug, more effective. And some people say less side effects, although obviously not from the injection site, where some people, but not everybody do have problems. The other thing is I wanted Len to respond because there's nobody in our group these days that has more experience with intermittent androgen deprivation therapy than Len. So Len, why don't you give Paul your thoughts on intermittent?
Sure. Yeah, I'm on my, let's see, I can't recall now if it's my second or third drug holiday from ADT. This is definitely the longest. I've been off now for, I don't know, about 17 months, something like that. And you mentioned, you used the word immediate earlier when you said, will they immediately put me back on Lupron if my PSA rises? the answer to that is probably not immediately. They usually want to let it rise a bit before they restart. And sometimes they might want to do that just so they can see where the lesions are that are producing the PSA. And if you try and restart it too soon, let's say if your PSA is less than 1 or maybe even less than 2, chances of the scans picking up the location of the lesions are pretty slim. So they like to allow it to rise oftentimes above 2, so that they can scan you and find something.
Yeah, I may have misspoken, Paul. When I was down to 0.5 on Lupron, and I said, oh, let's try intermittent. And the doctor said, no, it's not going to work for you. And I said, well, let's try it. And she said, okay. And within 8 months, mine went up to 15. So when I said immediately, that's what I meant. As Len points out, if it only goes up, a half a point or a point, then by all means, you can wait a while. There's no rush. So we're talking about 2 different people, 2 different cases.
Right.
Yeah. Paul, the other thing is that guys will vary as to how quickly their T levels recover. Mine recovered fairly quickly. Some people can go a year or longer before they start to see their T levels recover. It's partly dependent on your age, partly dependent on how long you've been on ADT prior to going on drug holiday.
Right.
Right. Okay. Now, when you went back on for the second time, why did it came up and then you went back on Lupron, and then why did you stop again? How long were you on Lupron the second time?
I think it was mostly Firmagon, only Lupron the last few months. I think it was about 15 months I was on it for the second time. And at that time, I also had radiation therapy.
Oh, you did?
Oh, massive doses of radiation, 86 gray at Sloan Kettering, and 46 or 48 sessions. And so I'm sure that contributed to the success of my being able to stay off ADT a longer time.
That's right. You didn't have a prostatectomy, is that right?
I never had a prostatectomy.
Right. Okay.
It was a bit of an unusual case. The first 2 years after I was diagnosed, all I got was ADT because my oncologist said, no, you're too far gone for surgery, too far gone for radiation. But then, Rick was pressing me to look into radiation, and eventually, I found, even at Sloan, a couple of radiation oncologists who said, you should definitely have this treatment. There's even they said a 10 to 15% chance that you could be cured. Well, that didn't happen, but because I never got to 0. But at least I've been on a long holiday.
Right.
I just want to add, it wasn't just me that was pressing him.
Yeah, Dominic also.
Yeah.
Peter, are you on this call? I see your name on the meeting organizers. Are you with us?
Yes, I'm with you.
Hi, how are you? We haven't heard you too.
I see Peter. Yeah.
Yes, I'm on here. Yes, I was busy, so I got on late, but I'm here.
Okay. Well, do you have any thoughts that you would like to add for Paul on intermittent?
No, only that you can get Lupron shot, 1 month Lupron shots. You can get a 7.5 milligram shot. There's nothing wrong with that. Most people go for 3 months, but I'm thinking about getting a 1 month shot. I've got to talk to my oncologist about it, but I'm thinking of getting one in October. when my time comes up, because I'm thinking of going. If he agrees to it, going off Lupron maybe in mid-November during my radiation, my proton radiation, and going back on a holiday, because I'm on Zytiga and Lupron, and I'd like to get off both of them perhaps in November and see what happens.
Peter, why do you want to go on monthly Lupron?
Well, my 3-month shot expires in October, mid-October, and I'll be coming through California again, getting a CT scan in San Diego. I'm thinking of bopping up to a prostate oncology specialist and just getting a 1-month shot, and then if it's agreeable, letting that wear off in November and going on a holiday then.
Oh, I see. Okay.
Len, where did you stay when you were getting your radiation at Sloan?
Where did I stay?
Yeah, I mean that was like a month and a half long process, right?
Yeah, it was 9 weeks, so over 2 months. I commuted to I forgot already, Paul. Where are you located?
Me? Oh, well, I'm southeast Florida.
Oh, that's right. Yeah. So I live in Connecticut, but I'm a half-hour drive from Sloan Kettering's Westchester office, which is about 20 miles north of Manhattan.
Oh, okay. All right.
That's where I got my treatments.
Yeah. Because the reason I asked is that going into the city every day is, can be a real difficult process.
That would have been a disaster. This is just a half-hour drive.
Right. You went to Upper Westchester. Maybe I can see it'd be a lot easier. Yeah.
Yeah. It's around the White Plains area. Matter of fact, you could see the White Plains skyline if you know White Plains.
Okay.
Okay.
Well, thank you for the information.
Anyone else want to talk to Paul about this? Rick, we didn't have anyone else who wanted to take the floor tonight, unless someone's changed their mind.
We didn't poll Larry Fish. He
Larry, okay.
And Peter, he might want to have something to talk about.
Yeah, no, I was okay, or I would have made sure to get on proper time because I didn't want to, try to beg my way in late as a latecomer. That's been like an issue. I was looking at the clock, it was 8:06, and I thought, I got to get there, even though I'm not going to say anything.
No, I'm glad somebody reads what we write. I mean, this is, I think, because of Labor Day, it's a smaller group than normal. So I really appreciate that, Larry. Again, you're coming up with some gems today, man. Thank you very much. I just wanted to say to Paul that we all wish you the very best on intermittent. Hopefully, I mean, you've been handling the androgen deprivation pretty well after a rocky start. I do remember that you had a pretty rough start on it, but the last 18 months or so you've been doing pretty well, but hopefully you're going to feel a lot better. And my own personal feeling about intermittent is that as long as you keep a close eye on your numbers, that you should be fine.
Okay.
But enjoy it and don't stress out. I mean, Len is a fantastic example of somebody who doesn't stress out when he's not taking the drug.
Yeah.
And if you stress out all the time that you're not taking the drug, it's not going to do you any good because you're just going to compromise your immune system.
Yeah, that's true.
Yeah, that's Yeah. Yeah. Well, anytime you make a change, it can make you nervous, but you know, after 3 years, that's quite a long time to be on the Lupron. So.
Well, it is, but you know, maybe it'll also help you get your weight down a little bit whilst you're off of it.
God, that's one of my big problem right now. I'm a big fat tub right now.
Paul, if you do go off, you probably want to monitor your testosterone. I'd be curious to see after 3 years how long it takes for some testosterone to come back into your system.
Yeah.
3 years is a big hit with androgen deprivation. It could take a long time to recover, but I'd just be curious, and you should be curious too. So ask your doctor if you can have regular testing for that.
Yeah, for sure. Yeah.
Yeah.
At least quarterly.
Yeah. Right. Yeah, I was just thinking staying on quarterly is probably all that's necessary until it starts to move. Then you go monthly.
They still have me taking them monthly because mine kept rising until I started taking Lupron without any breaks. And the problem is, if you have it recurrence, I wouldn't want to stop taking it and wait 3 months. Is that what you're talking about?
Well, I took a 3-month shot. Yeah.
No, I thought you were talking about stopping taking Lupron completely and then waiting 3 months for a testosterone test to see what was happening. And
Oh, yeah.
I would do it every month. I don't know if you could, because if it starts rising, I mean, my PSA started going up almost right away when I stopped taking it for 2 months.
Oh, is that? Yeah.
Well, I think it's probably more important to test your testosterone every 3 months, but it's probably wiser, at least at first, to keep a closer eye on your PSA.
Right. That's what I would think.
Because, you're not really sure. You want your testosterone to come back. I mean, that's exactly why you go off of it. But hopefully your testosterone comes back without your PSA going up. Isn't that the theory? I mean, you're the expert here.
Theory being what?
That you want your testosterone to come back without your PSA going up.
Right.
Oh yeah, of course.
Right.
Because when your T levels come back up, you can build up your strength, and in your case, you can lose weight. You'll have more energy to exercise. You can firm up your bone density, clear your mind, get rid of that brain fog. These are all the reasons why, if you can, it's good to take a break.
Just for grin, and remind us what your testosterone went up to again.
Well, the last check it was 800.
Oh, wow. That's pretty high.
Yeah, that's high for a normal guy that's never been on ADT. So.
Right.
Hey.
It gives you a goal to shoot for, Paul.
What's that?
Gives you a goal to shoot for. If Len can do it, then why not you too?
Well, I'm not all that concerned about the testosterone, but the PSA is what I want to not have to see. My doctor told me that he says that I specifically asked him. I said if the cancer has not had anything to feed on for 3 years, can I assume that all the cells are dead? And he says yes, sir. They're dead. So it's only castrate the other kinds of cells that might come back, and we don't know where they are or how fast they'll start to rise, but
I'd take issue with your doc, because there are two hypotheses. One is that all the cells die off, and then there are a lot of people that will tell you that they don't die off, they just go dormant.
Yeah.
and it's
Well,
not.
yeah, you could argue that if they don't have the testosterone, that they just stop growing fast, but they still stay there.
Right.
Correct. Yeah, that's a better scenario because Lupron is not a chemo drug. It's not going to kill things.
Right.
What-
Yeah. It's just cutting off the testosterone. Yeah.
Right. So what it's going to do is it's going to starve those cells. And some people say you starve the cells, they just die. And other
Right.
people say you starve the cells and they just go into a deep hibernation and then they come back alive. And, I don't know which is correct. I'm just putting forward the two hypotheses. And if I was talking to your doctor, I would ask him whether he thinks there's value to both.
Yeah. Well, no, he was pretty. I specifically asked him, and he was pretty. I mean, he gave me a very quick answer. He says, "Oh no, they're dead. They're dead as doornails." And but then again, in the medical community, there can be disputes. And sometimes the 7% that object are the guys that are right. So who knows?
Or they both could be right. Some are killed and some go dormant.
Right, exactly.
Right.
That's
Right.
what I would suspect.
Yeah. Right. Exactly.
Yeah. Anyone else have any thoughts on that, dead or dormant? It's a great discussion.
Well, Jake Hearn.
ADT is not considered a primary treatment. It's in conjunction with other treatments, particularly radiation. So I don't think the school of thought is that. I mean, I guess there are some people. I mean, I asked that question myself in my situation. I've got recurrent disease, and I'm back on Lupron and Zytiga, and I thought, well, maybe I'm doing, since I'm tolerating it so well, why don't I just stay on these drugs and not do any more radiation? And my oncologist kind of said, no, I think you should go with the additional radiation to the lymph node system. He didn't feel that ADT by itself was a good primary treatment, to not just stay on it. It's better off doing something else and getting off of it.
Peter, I just want to add, Jay, we'll come back to you, but I just want to add that ADT can be a primary treatment. It's often used as a primary treatment in older men who don't want to who aren't a good candidate for surgery and don't want to do radiation. But I mean, I accept your point, but it can be a primary treatment.
Yeah, I understand that. It can be, but it's more a default.
Yeah, I agree with that.
In my case, it's the only thing. I've had surgery, then I had radiation. Once there were 2 years after radiation, my PSA started doubling every month. So they had to put me on it, and I'm on it forever. And you can't do radiation again, from what I understand.
Right, but we're sort of
depends
talking,
on your case.
Yeah, we're sort of talking about a different issue with respect, Jeff. I mean, what Peter is really talking about, what we're really talking about is can you do as a primary treatment ADT? And as Peter says, you can do it, but it's sort of a default, because usually you would do something else like surgery or radiation, because surgery and radiation, you're more likely to be sure that you're killing the cells. When you just use ADT, you don't know whether you're killing the cells. And that's the discussion we're having. Does ADT kill the cells? Or does it just put them to sleep for a very long time, deep sleep?
Well, I appreciated hearing
I
that.
can weigh in because
hold on, Larry, hold on 1 second. Jeff, go ahead and respond.
I appreciated that when it was mentioned earlier that because in my case, I mean, maybe ADT will stop being needed after a couple more years.
Right.
That's exactly why.
So, Larry, we'll come to you, but Jay Curran was trying to get in before.
Yeah, I got a question about the sleeping cells and the killed cells. Does a scan know the difference?
No. The scan doesn't see cells.
No.
I think the answer there might be that it depends on the scan technology. Like the choline scans, they are dependent upon a metabolically active cancer cell picking up the choline. So that if you have an inactive or sleeper or dormant cancer cell, it's not going to take up the choline, and you're not going to see it on the scan. I'm not sure how the other scans would be in that regard, if they would pick up a dormant cell as well as an active cell.
Yeah, I mean, I would suspect that a dormant, but I don't know for sure, but this is just a guess, that a dormant cell doesn't produce PSMA either.
Yeah, probably not.
It's a good question, Jay. I tend to think, just as a layman, that it would not pick up dormant cells.
Thank you.
Larry?
All right. So I'm one of those people that came into the game with probably extensive bone mets. So Lupron was my primary treatment, and I never had a prostatectomy or radiation, although we talk about doing that, whatever you call that, the going back and debunking the primary. We discuss that idea once in a while, my doctor will explain that the cells, they're not dead, they're dormant. They don't disappear. They just aren't eating. They're kind of in this is what I think they used to call remission. Don't use that term in general, but I think it just means that they're dormant and that they will become active. That the thing the other thing was that getting a combination of bone scan MRI, they can pick up a lesion, but they can pick up activity, or they can pick up an actual lesion, or a lytic lesion, or a blastic lesion, I guess it's called. So it could either be an additive or a subtractive bone issue, but not that it's going to pick up activity in dormant cells. That was her opinion.
So would you think that are there scans that you think would pick up dormant cells, or would no scan pick up a dormant cell?
I never asked that question. If they can get down to that cellular level and pick up if a cell is a cancer cell, I think it's really it's like an undifferentiated cell that is not serving its purpose. The cell divides. It doesn't differentiate into a functional cell, and it's just there. I don't know that they know if it's doing something or not until it's inhibiting a function or protecting something, or a lesion is showing, or it's showing metabolic activity. I don't know that it would be picked up, but I certainly am not an expert about this.
So let me rephrase it. Let's assume that there's a 3 billion dormant cells all lying together in a mass.
Then I think it's the mass that you could see. That's not, you have a mass that is not functioning as an organ or whatever it would be functioning as.
Okay,
so you see a growth, and it's by the comparison. So if you're getting multiple scans, you're comparing scans, you see a change. That's what my doctor said.
But my question is, do you think that a scan would pick up 3 billion dormant cells or not?
No idea. It's a very good question. I'll try to ask my doctor, do scans ever pick up a bunch of dormant cells somewhere, other than like a change in bone density?
Because I think we're kind of loose with the language. When we say a cell, we don't really mean a cell. We mean a whole bunch of cells together. Because we recognize that these scans are not on a cellular level. But what they're picking up is a bundle of cells. And if a bundle of cells doesn't produce choline and doesn't produce PSMA and doesn't show any bone activity, which it wouldn't do if it were dormant, is there any chance that that bundle of cells would be picked up on any type of scan? And, you know, I like Larry and everybody else and Len, I'm not an expert, I don't have the knowledge, but I tend to think not.
Yeah, I would tend to agree. As I said, definitely in the case of the choline, if it's not being taken up, it's not going to be visualized. Also, you've probably heard of the FDG scans, fluorodeoxyglucose. If the cell, as it is, prostate cancer cells don't take up sugar at as high a rate as other cancer types do. And that's why the FDG scan, prostate scan, is not terribly good to begin with. Now, if the cells are not metabolically actively growing and dividing, then it's even more difficult to distinguish the prostate cancer cells from ordinary cells that are picking up the glucose from the FDG tracer.
Right. Peter, do you have any thoughts on this?
Only that I mean the big thing that we have going for us is that prostate cancer cells are slow growing. That and you know, I've always heard the word microscopic. You know, there's a good chance, like in my situation, that I've got microscopic cells throughout my lymph system. But right now, only two lymph nodes are showing up, is lit up. But the odds that there's cancer cells in other ones is pretty great because it's one system. But because it's so slow growing, you know, perhaps they just won't show up for a long time. So that's not true with everybody. I mean, sometimes with prostate cancer, it's very fast moving with a very aggressive disease, particularly with heavy metastatic disease. It could be pretty fast moving.
Mm-hmm.
But in other situations, it kind of plods along and probably doesn't show up too much.
So, you know, we're heading into the last few minutes here. We haven't heard anything from Les or from really nothing from Jay other than a response. Do either of you guys want to say anything before we?
This is Les. I've got a question if you have a minute. I'm trying to understand the use of different things to determine if a treatment is working or not. You know, some have talked about the increase in the PSA. Some have talked about if you have different functions or your disabilities or something, some physical thing that you feel. Some have said that with a high Gleason score particularly, that the PSA is not a good instrument to go by. And you know, I'm getting so many different directions here. Like Dr. Luke Nordquist had commented on that he didn't like to go by some other things. He liked to go by what your symptoms were. Well, in my case, I have never had any symptoms. You know, I've got Gleason 10, prostate cancer. When my PSA gets turned loose, the doubling time is something like 6 weeks. and yet I've never had any symptoms. So how do you know if something's working or not?
I would say bottom line, you can't refute the evidence of a scan. If a scan is not picking up lesions, I would rest pretty easy.
Well, that was what I was thinking too. That's one of the reasons why I've stuck with Dr. Eugene Kwan from Mayo Clinic. That so far he's been the only one that I've worked with that has been using any kind of a real scan. But I hear so many things from other places that trying to figure out just what to go by.
If your PSA is below a certain point, you cannot use a scan. So isn't that one of the major criteria that you're testing your PSA?
Well, yes, but you cannot use a scan to determine if you've got Mets, but if you already have metastasis, it's going to show up. So we're maybe talking at cross purposes here. You cannot use a scan to see where metastasis might be if you don't have metastasis. But if you do have metastasis, it's going to show up. Your metastasis is going to show up even if your PSA is undetectable. Does that make sense?
Yes, for me, yeah.
Yes.
Does that make sense to you, Jeff?
Yes, I did not realize that.
Right. So I just want to come back. I want to come back to you, Les. I learned kind of the hard way, not through my own experience, but through working for several years with Dom, God rest his soul, who always insisted that the only way to know if your disease is progressing is to scan it regularly. And on this call, we encourage people to scan regularly. I think you've heard that. And if your doctor isn't scanning you, we say go in and make sure you get a scan. If you've got metastatic disease, at least once a year, if not more often. And I absolutely endorse what Len says. And I don't think that there's a center of excellence in the country that would not agree with that. So I don't know who or where you've been comparing, but if you went to someone like somewhere like Northwestern or University of Minnesota, for example, or I don't know, Duke or anywhere, they'd be scanning you on a regular basis. You may not be happy enough. You may not be happy that it's frequent enough, but they're going to be scanning you on a pretty regular basis. I can't speak for the independents. I really don't know how often prostate cancer oncologists recommend a scan. Peter could probably address that. I can't speak for Nordquist, although I suspect that he would scan on a regular basis.
He just uses the CT scan, etc. He does not have the facilities to do anything what I would consider more elaborate, like what they do at Mayo.
Okay, but now we're talking a different issue. Now we're talking about, well, what type of scan should I be? All right, that's a different issue to people getting regular scans. And, you know, we can argue whether what they do at Mayo is the best available. I personally don't think it is. I think that there is better technology available than what Mayo is using, but they're still scanning you.
Yes.
And, you know, is it better than what Nordquist uses? Probably is. But if you went to Nordquist and said, I want this type of scan, he'll find a place where you can get that type of scan.
Yes, and he sends them to Mayo.
Okay. So, you know, just because they have the technology and they do the scan doesn't, for me, I mean, it's everybody's choice, but it shows that they are diligent. I'm not sure that it speaks to the treatment methods that they're using, because they're different issues. Now, I would encourage everybody to get scanned, and if possible, to get PSMA scanned, because that's probably the best type of scan, or this new F18 pyridium, if you can get to it. That's going to show you the most and give you the best comparisons. But if all you can get is a CT scan, which is what a lot of our guys get, it's still going to show you enough to make the comparisons. You know, the better the scan, like for example, the PSMA, the more likely it is to show you if the cancer's recurred. But once your cancer's recurred, you're using the scans for a different purpose. You're using the scans to see whether the treatment is working, not to see whether you need treatment.
Again, I tried to get a PSMA, but was told my PSA had to be above 0.02 in order to get it. So I was unable to do it since it was below that.
I think it's 0.2, not 0.02. But
okay. Yes.
But
yes.
Again, yes, there is a lower threshold for these scans, and if your threshold is below that, probably saying don't get worried right now. You know, it could be overkill if your threshold's below it. Don't worry. When you get to the threshold, then we'll take a look. So all you know, Les, I just want to come back to your concern. How do you assess whether treatment is working? Well, there are measures like PSA, which we all know, which isn't that reliable the more advanced the disease. There are measures like alkaline phosphatase, which can be quite helpful because it shows bone activity, except you never quite know whether it's bone activity from the disease dying or the disease spreading. So you have to look at it in the context of the treatment that you're doing. And you can look at scans, which are probably the best thing if you're not symptomatic. And I would have to say, having heard Nordquist speak, and I was really impressed with him, I suspect that he's doing all of that. He's not just waiting for you to tell him. He's not going to do, I doubt he would do nothing until you said, oh, I feel pain here, there, or somewhere else. But that's just my guess. I can't say that for certain. I can't speak for him, but I just don't think so. Peter, how often do your friends in Marina del Rey recommend scanning?
I think it's my experience is whenever necessary. I mean, as soon as my PSA started doubling, you know, showing it was doubling, scanning right away. And the best place to do it and the best scan to have, Turner, I was thinking of Oxamin, and Turner said, no, you really should get a PSMA scan. So that's when I
right.
Searching that and jumping on. I mean, they're not a hospital and they don't do scans themselves, but they're on top of the game. I mean, they're looking.
Right. Les, where are you with your treatment decisions?
I decided to go with the radiation. I know there's been strong opinions in both directions. Each side, pointing at the other, say that's the wrong way to go. But I've had strong opinions on both sides, and finally decided to go with the recommendation from the Mayo Clinic and proceed with the additional radiation.
Okay, and when are you starting?
Not a specific date yet. I'm leaving tomorrow to get fitted, what they call simulation, to get my tattoos and everything, and then they'll give me a date from there, which would probably be the middle of this month, starting 5 weeks of radiation.
And what type of radiation is that?
Can't think of the name right now, offhand.
Okay.
Is it SBRT?
IMRT, SBRT. Are they putting markers in? I mean, the tattoos are just very, very rough. Are they putting markers in?
All I know is the tattoos. That's all they had told me.
Well, you know, it's not uncommon. I forget. Do you have a prostate? I'm just looking now.
No, I did not have the surgery. So it was killed by the radiation initially.
Right, but they can put in gold markers, and one would hope that they're either putting in gold markers or transponders, because those are the only technologies I'm aware of to get accurate radiation today.
Yeah, Rick, I think he just said that he had initial radiation already. Is that right, Les?
Yes.
Yeah.
He did.
At the beginning, they put me immediately on radiation and hormone right off the bat.
So
that's been 5 years ago.
Yeah.
5+.
So I think those gold fiducials, Rick, aren't they only for your primary radiation? Because
No,
they put them in your prostate.
Yeah, but they can also put them in the prostate bed.
Oh yeah. Okay.
And they can put them in other places, but you know, I think the purpose of it, and if they don't, I'd just be asking them, well, how can you assure accuracy?
Well, they're radiating the lymph nodes.
Peter, have you had that discussion? Or maybe it's different with proton beam?
Yeah, well, the big thing is they can't radiate the same place twice.
Right.
So he's already had, like me, IMRT to the prostate bed. You know, yes, he got radiation to the prostate, but if they want, you know, IMRT will spread around the prostate bed too. So they got to be doing something different, like what they're doing with me, and radiating the abdominal stuff. Anything north of the pelvic girdle. Is that what's going on, Les?
Yes. Yeah.
Yeah. So there's no gold markers or anything like that. They just need really accurate targets. So hopefully they'll do a really accurate scan, and they also have to know really specifically where the previous radiation was, because they can't any place near that. You know, you don't want any overlapping in terms of radiation.
Yeah, so local information was sent to them some time ago, showing the mapping of where the radiation had been done. So they have that information.
Right.
So Peter, you're saying that there's no technology with transponders or gold markers that is used when you are aiming higher?
I don't believe so, because you're dealing with lymph nodes. In my situation, it sounds like the same is true with Les's situation. You know, I don't know about bone or other tissue, but they can target these things pretty well without
okay.
markers, I think. I mean, that's my understanding. I'm going to meet with them for an initial setup scan about a month from now in October, and I'll talk to them about that. And I'll also talk to Turner about it when I see him next week. It's my
I would definitely be asking the question about that. That's what would concern me. But you know, maybe there is nothing. So this is how we learn. Anyway, guys, look, I want to thank Jake and Len for sharing the burden this week. It was really, really helpful for me, and I think they both did a really great job. Even though sometimes we have to pull it out of Jake, he does an excellent job. And don't you agree, Len?
I agree. Absolutely does. Couldn't do it without him.
Right.
Thank you for that, but I panicked when you told me you were going to be late. I called Len right away. I said, please make sure you're there at 8 o'clock.
You do great, Jake. And we're going to keep telling you that until you tell us. And when you tell us I do a good job, then we'll know we got the message home. I think today's session has been, there's a couple of really big things that came out of today's session for those people that are on long-term hormone therapy. One is make sure you get regular bone density tests. And, the other is this issue around metabolic syndrome and whether you should be making statins part of your treatment protocol, even if you have low cholesterol, because the lower the statin, the lower the cholesterol, the better off you are. And I think that's appropriate, not only for all of you who are on that treatment, but for anybody who's listening in. That's very, very helpful information. The last thing I just want to say is that we're at PCRI, and most of you have now seen we are going to be hosting a reception. And as far as I know, we've got around close to 35 people that have already confirmed, and hopefully there'll be more than that, and everybody's welcome. And we hope you all show up and introduce yourselves to us so we can put faces with names if you haven't done that yet. And if you have done it, it'll be good to see you all again. I am leaving early Wednesday morning to go to Minneapolis for Rob's arrangements. And then I'll be flying into LA pretty late on Thursday night. So I'm apologizing to Len in advance if I wake him up when I come into the room.
I forgot to ask, you don't snore, do you?
I don't want to tell me if I do or I don't, but I can tell you the chances are that I will wake you up when I come into the room. The flight's due in at about 11 o'clock.
Okay, I'll take some Ambien.
There you go. You're up till all hours of the night, Len, so you won't even be asleep by the time I get back.
Yeah, but I have to get up early Friday, so I am going to try and get to bed early Thursday night.
Uh-oh. Okay, I'll be quiet. As quiet as I can be. Speaking of which, Don Price is supposed to be around, so, if I run into him, he can teach me how to be quiet as a mouse. So, I'm not, I won't be speaking publicly, but I will convey any chance I get how important Rob has been to us, how much we miss him already. As Jake will attest from our discussion before this call earlier today. And he's just not replaceable. So you'll see that we've renamed the room in his honor, this room. And that's about all I have to say. Next meeting will be next Tuesday. I'll be in LA. I'll conduct it from there. And Peter's meeting is next Monday. And thanks again, guys.
Okay. Good night.
Good night, everybody.
Good night, everybody.
Good night, guys. Good night, Sylvester, who didn't speak the whole night.